Welcome to the Panel Management Module Series. Today's topic will be Diabetes Panel Management. The goal of this module is to help you to learn why panel management is important in diabetes, review the current diabetes guidelines, learn how to use a diabetes registry to build panel lists, and finally begin panel management with your diabetic patients. Let's start with a quick review of what panel management is. Panel management is the process of engaging your primary care patients outside of the regular office setting, the goal of which is to meet their preventative and chronic care needs. In other words, panel management is a systematic way of approaching the care of a patient with a chronic condition in order to ensure they are receiving all the guideline-based recommended care. What this requires is switching from thinking about patient-level outcomes, such as in this example the hemoglobin A1C of one particular patient, to panel-level outcomes, such as what percent of my panel diabetics has an A1C greater than 9%. Why is this important? Well, according to a report put out in 2013 by the National Committee for Quality Assurance that looked at outcomes for over 130 million American patients, only 40% of all diabetics had an A1C in the good control range of less than 7%. If you had to guess, what percentage of American diabetics do you think has an A1C in the poor control range greater than 9%? Surprisingly, the correct answer is E. About 28%, or almost 30% of all diabetics are considered poorly controlled, with an A1C over 9%. This is important because poorly controlled diabetes is strongly associated with many of the major complications of diabetes, from eye disease, nerve disease, kidney disease, and cardiac disease. Importantly, the most benefit we can get in preventing these complications is by focusing on patients under poor control and bringing them back to the fair control range of 7 to 8%. Okay, let's review some of the guidelines. How often do you check the hemoglobin A1C in your patients with diabetes? The correct answer is D. According to the American Diabetic Association, in patients who are meeting their A1C goals, we should check their A1C every 6 months. If they are not meeting their goals, we should check every 3 months. Okay, how often should we check lipids? Well, there are actually two answers to this question. The answers are B and C. For most diabetics, the ADA recommends annual lipid screening. However, in selected patients, if their LDL is less than 100, HDL is greater than 50, or triglycerides are less than 150, you can consider screening every 2 years. Despite these guidelines, the NCQA found that only 85% of diabetics have had lipid screening in the last year. Among those screened, only 48% had actually achieved the target LDL of less than 100. Okay, let's review another guideline. According to the ADA, what is the blood pressure goal of a diabetic patient? The correct answer, according to the ADA, is less than 140 over 80. Unfortunately, only about 44% of diabetics have achieved that goal according to the NCQA. What about nephropathy screening? How often should we be checking urine microalbumin? The ADA recommends annual microalbumin screening in all type 2 diabetics, as well as 5 years after diagnosis of type 1 diabetes and annually thereafter. How well are we doing with this recommendation? Only 84% of diabetics have had this recommended screening. What about retinopathy? How often should patients receive retinopathy screening? The answer is B. The ADA recommends retinopathy screening at the time of diagnosis for all type 2 diabetics and 5 years after the diagnosis of type 1 diabetes. If no retinopathy is found, the ADA recommends screening every 2 years. If there is retinopathy, then this should be followed by an annual eye exam. How well are we performing with this recommendation? Only 56% of diabetics have had this recommended screening. Okay, you may be thinking to yourself, keeping track of all this seems kind of hard. Well, it doesn't have to be. Enter the panel list. This is an example of a list of all the diabetic patients on a resident's primary care panel. Notice that this list automatically pulls in patients' last 2 hemoglobin A1Cs, their most recent LDL, the date and result of their last urine microalbumin to creatinine ratio, their last recorded blood pressure, their last foot exam, as well as their immunization record. You may be wondering to yourself, how do I access this list? It's easy. First, you need to have approval. If you do not yet have access, talk to the clinic leadership and this can be arranged for you. Once you've been approved for access, you simply open up the VA intranet webpage, which is the default when you open up Internet Explorer on any VA computer. Feel free to pause this module to try it out for yourself. Mouse over the Clinical Resources tab, then select Diabetes Registry. This website will open up. This is the main interface for you to build your diabetes list. To pull up all your patients, simply click the View button, highlighted by the red arrow next to all diabetic patients. Also notice you can create custom lists sorting by A1C, LDL, and blood pressure. You can also build lists of patients who are missing components of their chronic diabetes care, such as A1C or LDL labs. Once built, you can view your patients and begin addressing their care needs. You can also export this list to Excel, or print it out for use with your healthcare team. You may have noticed that retinopathy screening is not included in this registry. This feature has not yet been enabled, but for any given patient, you can go to CPRS and look for any of the following note titles to see if and when retinopathy screening has been done. Okay, you have a whole bunch of data, but where do you start? Remember, the highest rate of complications are with diabetics under poor control, with an A1C greater than 9%. This is probably a good place to start. Here's a list of patients whose A1Cs are all above 9%. We can further break these patients down into certain patterns. Someone who was previously controlled but now isn't. These patients may be a new diagnosis of diabetes. You should also look for some changes in their lives, usually social, that might explain this. You should also probe for mental health and substance abuse problems in these patients. Next, we have patients who are missing in action. Notice, the last A1C was several years ago. These patients may simply be lost to follow-up. In general, they are easy targets. You should enlist your administrative staff to schedule these patients for labs and appointments. The next group is patients who are chronically uncontrolled. These are a more difficult group, as there is usually some kind of major barrier to their success, frequently socioeconomic. This is a good time to utilize your multidisciplinary team, including care management, social work, pharmacy, and nutrition to help these patients. Finally, we have patients who were previously poorly controlled, are improving, but not as quickly as we'd like. These patients may benefit from further educational efforts, either from your care management team or from nutrition. They will often benefit from closer proactive contact from your team. As always, don't forget to probe for social, substance abuse, and mental health barriers. Using some of these patterns, you can begin to approach your poorly controlled diabetic patients. Once you've done that, you can also start to look at the rest of your panel. Make sure that they're meeting their guidelines recommended care. Have they had an A1C in the last 6 months? Lipid screening. Is their blood pressure at goal? Have they had a nephropathy screening, ophthalmology screening, a foot exam? You can also look at the following list of resources available at the VA and see if any of them would be helpful for your patients. One way to break down these lists is to spend one panel management session addressing all unmet labs and screening for your patients, and another session seeing if any of the referrals on the right of the screen would be helpful for your patients. You can then make a care plan for individual patients. Here's an example, where you identify care needs, barriers, and formulate a stepwise plan to address those care needs. It may be also helpful to use a table, pictured on the bottom, to help you organize tasks for your healthcare team. You can now carry it out. This is a great time to use your care team. Remember, you're not alone. You should also seek feedback on your care plan. This can be achieved by staffing your plan with an attending, much in the same way you would a regular clinic patient. Start like you normally would. Report the most recent A1C and their goal A1C. Categorize their trend according to the patterns we discussed earlier. Tell your attending what the patient's major barriers are. Then, list the major unmet care needs. Tell the attending your plan and ask for feedback or suggestions to help you achieve those plans. You will also receive periodic panel reports. Here's an example of one. Each blue dot represents a patient panel. On the x-axis, the percent of panel diabetics with well-controlled blood pressure is listed. The further the right, the better. On the y-axis, the percent of panel diabetics with an A1C greater than 9% is listed. The lower the better. The green box in the bottom right-hand corner of the graph is the general target for all panels. With these graphs, you can track your panel over time, aiming to be in the green box. Okay, armed with this knowledge, it's time to start the practice of accessing and using the Diabetes Registry. Try to use as many of your local resources as possible. Don't forget to ask for feedback, and go ahead and get started.